All right, so you're here because you want the good stuff, right?
Yeah,
The need to know information without all the fluff and filler. You want to actually understand things. Well, today we're doing a deep dive on something that comes up quite a bit, actually, both in dentistry and medicine, and that's cysts of the jaws and neck.
yeah, we've got a whole bunch of sources here all talking about cysts. We've got clinical descriptions, discussions of how these things start, what they look like under a microscope, on x-rays, you know, what else it could be, and then, of course, how they're treated.
We're going to try to pull out the most important points so you can really grasp what these different types of cysts are all about.
Absolutely, how they look, how they act, and, of course, how we deal with them.
So first things first, what exactly is a cyst? I mean, it sounds simple enough, but
Right. Well, at its most basic, it's a cavity, a pathological cavity, and it's lined with epithelium. That lining is really what makes it a cyst.
okay, epithelium. So that's like a layer of cells, right?
Exactly. Now, there's also this thing called a pseudocyst. It looks like a cyst, but the difference is it doesn't have that epithelial lining. So we have true cysts and then these pseudocysts.
Interesting. So right off the bat, there's a major distinction there. All right, let's jump into our first big category. Odontogenic cysts.
Okay, so we're talking about cysts that come from tooth-forming tissues.
Right. And I guess the most common one that we see in the jaw is the periapical cyst, also called the radicular cyst.
This is the one, yeah. What's really interesting about these periapical cysts is that almost all of them develop from a pre-existing periapical granuloma. It's this little area of chronic inflammation that's sitting right there at the very tip, at the apex, of a tooth that's no longer vital.
So that brings up a good point. These cysts really highlight how important dental health is, even for the bone.
Absolutely. Taking care of your teeth isn't just about saving the tooth itself. If you let that decay progress, you can end up with these issues in the bone like these cysts we're talking about.
So we've got this non-vital tooth. Then how does this inflammation actually turn into a cyst? What's the process there?
Well, the breakdown of that dead tissue inside the tooth is kind of the first domino. That stuff, the debris from the dead tissue, it triggers inflammation, and that can stimulate these little groups of cells that are left over from when the tooth was developing. They're called the rests of molasses.
Rests of molasses, so they're just sort of hanging out there.
Yeah, they're usually just kind of dormant in the periodontal ligament. But when they get stimulated by this inflammation, they start multiplying, they proliferate, and eventually they form that epithelial lining that defines the cyst. And you know what the cyst does? It basically walls off that inflammation from the surrounding bone.
It's like it creates a barrier.
Exactly.
So if you're a clinician, what are the signs that someone might have a periapical cyst? What are you looking for?
Honestly, a lot of times there aren't any obvious symptoms. It's what we call asymptomatic. It's not unusual to find them just by chance. Someone gets dental x-rays for something else entirely, and there it is.
Just pops up.
Yeah, and they tend to show up more in the maxilla, the upper jaw, especially around the front teeth. One thing they do is cause bone resorption. They eat away at the bone, but they don't usually cause the bone to actually expand or swell outward. And of course, the tooth has to be non-vital. That's a must-have for this diagnosis. If the tooth is vital, it's probably something else entirely.
And what about on those x-rays? Does it look distinct? Can you tell it's a periapical cyst just from the x-ray?
This is where it gets a little tricky. You can't tell for sure if it's a periapical cyst or just a periapical granuloma by looking at a standard x-ray. They both show up as these dark areas, radiolucencies, at the tip of the tooth root.
So how do you tell them apart then?
You got to look at the tissue under a microscope. That's where histopathology comes in. It might look the same on the x-ray, but the microscopic view tells the real story.
Okay, so under the microscopes, what would you see that tells you it's a cyst and not just a granuloma?
The key is that lining. A cyst has a lining of non-keratinized, stratified, squamous epithelium, and there are often inflammatory cells in there too. That epithelial lining is what makes it a true cyst.
So let's say you see this dark spot on an x-ray at the tip of a non-vital tooth. What else could it be? What are some other things you'd consider?
Well, you got to look at the whole picture, right? The patient's history, everything. If they've had surgery in that area before, it could be a defect from the surgery or even a scar. In the front of the lower jaw, the anterior mandible, you might think about periapical cemento-osseous dysplasia. But here's the key difference. The teeth in that area are usually vital, meaning they have a healthy blood supply. And then further back in the mouth, it could be a traumatic bone cyst. And again, the teeth would be vital there too.
So knowing if the tooth is vital or not is really important.
Absolutely. It helps you narrow down the possibilities.
So how do you get rid of these periapical cysts? What's the treatment?
Usually you tackle the problem at its root, literally. You do a root canal on that non-vital tooth. Sometimes you might also do an apicoectomy, which is where you surgically remove the very tip of the root. And then you do what's called curettage, where you carefully scrape away the lining of the cyst and any inflamed tissue around it.
But I imagine you want to get all of it out, right?
Absolutely. You don't want to leave any of that cyst lining behind because it can lead to a residual cyst forming later.
Yeah.
And if you just leave the cyst untreated, it can keep growing and really damage the surrounding bone.
Okay, that makes sense. Let's move on to another type, the lateral periodontal cysts.
All right, so this one, as the name suggests, it's hanging out on the side of the tooth root.
On the side, okay.
Yeah. And it's what we call a non-keratinized developmental cyst. That means it comes from leftover tissues from development, not from inflammation. And another key point, it's always associated with a vital tooth.
Got it. And there's also the gingival cyst of the adult, right? Is that related?
Yeah, they're actually considered counterparts. They're histogenetically very similar. It's basically the same type of cyst, but in a different location. The lateral periodontal cyst is inside the bone, right next to the tooth root, while the gingival cyst of the adult is in the soft tissue of the gums.
So same kind of cyst, just different addresses.
Exactly.
And what causes these lateral periodontal cysts? Where do they come from?
Well, the thought is that lateral periodontal cysts come from these things called rests of lamina remnants. They're found within the bone. And the gingival cyst of the adult, those are believed to come from rests of seres, which are located in the soft tissues.
Rests of lamina remnants, rests of seres. These names are a mouthful.
Haha, I know, right? But they're basically just little groups of cells that are left over from when your teeth were developing. You see, there's this thing called the dental lamina, which is this epithelial structure that gives rise to your teeth. And even after your teeth are formed, sometimes these little remnants can decide to become active again and form a cyst.
Fascinating. So are there any telltale signs or symptoms of these cysts? And is anyone more prone to getting them?
Well, men are slightly more likely to get lateral periodontal cysts, about twice as often as women.
Yeah.
They tend to pop up in the mandibular, premolar, and cuspid regions, and sometimes in the incisor area. Now, gingival cysts, since they're in the gum tissue, they show up as these little soft swellings in the interdental papilla, that's the gum between your teeth. And sometimes they might even have a bluish tint to them.
Okay, bluish. That's interesting.
Yeah, they're usually pretty small, less than a centimeter across, and a very important point is that the tooth associated with them is always vital.
Always vital. So how do they look on x-rays?
So with gingival cysts, you're not going to see anything on a standard x-ray because they're in the soft tissue, in the gums. But lateral periodontal cysts, those usually show up as these well-defined round or teardrop-shaped radiolucencies.
Yeah.
Basically dark areas on the x-ray. And they're on the side of a vital tooth root. They can also be multilocular, meaning they have multiple little compartments, kind of like a cluster of grapes. You might see a thin, opaque border around them on the x-ray.
Multilocular. Got it. So anything else that's distinctive about them on x-rays?
Well, it's rare for them to cause the roots of the tooth to separate and diverge. And they don't usually cause any resorption of the tooth root. And if a lateral periodontal cyst does have that multilocular appearance, it's often called a botryoid odontogenic cyst. Just another name to remember.
Right, another name. So many names to keep track of. What would you see if you looked at one of these lateral periodontal cysts under a microscope?
Under the microscope, you'd see a thin layer of non-keratinized epithelium. But what's really helpful for making the diagnosis is that there are these glycogen-rich, clear cells within that lining. It's a pretty distinctive feature.
Okay, clear cells. Got it. And how do you treat these lateral periodontal and gingival cysts?
Usually it's a pretty straightforward procedure. You just surgically remove the cyst,
Yeah.
and that usually takes care of it. But those multilocular botryoid cysts, those have a bit of a higher chance of coming back. So we usually recommend follow-up appointments to make sure they haven't recurred.
All right, makes sense. Let's talk about these gingival cysts of the newborn, also called dental lamina cysts or Bond's nodules. These seem pretty specific to babies.
They are. We're talking about these tiny little bumps on a newborn's alveolar ridge, the gum ridge. They're filled with keratin.
Keratin, like what's in our hair and nails?
That's the one.
What causes these in newborns?
Well, it's basically little pieces of the dental lamina that get left behind after the teeth start to form. Remember that structure we talked about earlier, the dental lamina? Well, sometimes little fragments of it stay in the alveolar mucosa, and those can proliferate and form these little cysts.
So they're kind of like leftovers from tooth development.
Yeah, you could think of it that way.
So you see these little bumps in a newborn's mouth. What do you do?
The good news is You don't have to do anything. They go away on their own.
Oh, really?
Yeah, they involute, we call it, which basically means they disappear. And it usually happens within a few weeks or months, so parents might notice them, but they're not really a cause for concern. They'll sort themselves out.
That's good to know. Okay, let's move on to the dentigerous cyst or follicular cyst. You said this is the second most common odontogenic cyst and the most common developmental cyst.
Yeah, it's a pretty frequent one. So picture this. You've got a tooth that hasn't erupted yet. It's still under the gums. And a cyst forms around the crown of that tooth. That's your dentigerous cyst. It's attached right at the cemento-enamel junction, which is where the enamel of the crown meets the cementum on the root.
So it's like the tooth is stuck inside a fluid-filled balloon.
Exactly. And we think this cyst forms because of the proliferation of remnants of the enamel organ, or the reduced enamel epithelium. Again, it's all connected to tooth development.
So which teeth are we usually talking about here? Which ones are most likely to have these cysts?
The usual suspects are impacted third molars, those wisdom teeth that don't come in properly,
Yeah.
and maxillary canines. Those are the ones that tend to get impacted most often. We see the highest number of these cysts in young adults, people in their teens and 20s, and they're slightly more common in men.
Would someone know they have a dentigerous cyst? Are there any symptoms?
A lot of times there aren't any noticeable symptoms. It's asymptomatic. The main clue is usually that a tooth hasn't erupted when it should have, so it's a delayed eruption. But sometimes, if the cyst is big enough, you might see a little bulge or expansion of the outer layer of bone, the cortical bone. But it's pretty rare for it to actually cause a fracture in the jaw.
And on an x-ray, what does it look like?
On an X-ray, it usually looks like a well-defined, single dark area, a radiolucency, and it surrounds the crown of that unerupted tooth. The tooth itself is often pushed out of its normal position. And these cysts can be pretty variable in size. Some are small, but others can get quite large. And those bigger ones can weaken the jawbone and even make the face look asymmetrical. You might even see some resorption, some wearing away of the roots of the teeth next to it.
What about under the microscope? What would you see there?
Under the microscope, you'd see that the cyst wall is made of fibrous connective tissue, and it's lined by stratified squamous epithelium. Sometimes you'll see these things called Rushton bodies in the epithelial lining. But they're not really that important. They're just kind of an incidental finding.
Rushton bodies. Okay. And how do you treat a dentigerous cyst?
The standard approach is to surgically remove the unerupted tooth and the whole cyst sac. We call that enucleation, removing the entire cyst. Now, if the cyst is really large, the surgeon might do something called marsupialization first. That's where they create a little window into the cyst to release the pressure and shrink it down a bit before they remove it completely.
So why is it so important to remove them completely?
Well, there's a small chance, but it's still a chance, that the lining of a dentigerous cyst can turn into an ameloblastoma. That's a benign tumor, meaning it's not cancerous, but it can be locally aggressive and destructive to the surrounding tissues.
Okay, that makes sense. So better to be safe than sorry. Let's move on to the eruption cyst. This one sounds pretty self-explanatory.
It is. It's basically fluid building up around a tooth that's trying to erupt, to come through the gums. It happens in the follicular space, the area right around the crown of the tooth, and the lining of this space is the reduced enamel epithelium.
So what would you actually see in the mouth?
You typically see a swelling over where the tooth is trying to erupt. Sometimes it can even look bluish or purplish. And if there's been a bit of trauma, like if the area's been bumped, you might see blood in the fluid. We call that an eruption hematoma.
So does this usually need any treatment?
Most of the time, it takes care of itself. The tooth will usually just erupt right through the cyst, and the cyst will disappear. It's a self-limiting thing, meaning it resolves on its own.
That's good. Now, what about this glandular odontogenic cyst, sometimes called a sialo-odontogenic cyst? That glandular part makes me think of salivary glands.
You're right on the money. The interesting thing about this cyst is that it looks a lot like tumors that come from salivary glands when you look at it under a microscope. That tells us there might be some connection there, some shared features between them.
Huh, a link to salivary glands. That's pretty fascinating. So where do these glandular odontogenic cysts usually show up, and who's most likely to get them?
They really like the front of the lower jaw, the anterior mandible. About 80% of them are found there. They tend to grow slowly, and people don't always notice them at first. But as they get bigger, they can cause the jaw to expand. The average age when they're diagnosed is around 50 years old.
Okay, so no early warning signs then. What about on x-rays?
On x-rays, they usually look like these multilocular radiolucencies. They have multiple compartments, kind of like a honeycomb or soap bubbles.
Yeah.
They usually have pretty well-defined borders.
Multilocular, okay. And if you look at one under a microscope, what do you see?
Under the microscope, it's a multilocular cyst lined with non-keratinized epithelium. You'll see some areas where the lining is thicker. And here's the key. There are mucus cells clustered in the lining. And often you'll see little pools of mucin, which is the stuff that makes up mucus. That's what connects them to the salivary glands.
Ah, so that's the connection. And how do you treat these? Anything special to keep in mind?
You surgically remove them. But these cysts have a bit of a reputation for coming back, recurring. The recurrence rate is about 25%. So you really need to follow up with the patient and make sure it hasn't come back.
Okay, so close monitoring is important. Now let's talk about the odontogenic keratocyst, or OKC, sometimes called a keratocystic odontogenic tumor, or KCOT.
Ah, yes, the OKC. Now, these can be a bit more tricky, a bit more aggressive than some of the others.
In what way?
Well, for one, they have a higher chance of coming back after you treat them. And they're also linked to this genetic condition called nevoid basal cell carcinoma syndrome, or Gorlin-Gold syndrome.
So there's a genetic component to them. Interesting. Where do these OKCs usually come from?
We think they develop from remnants of the dental lamina, those little leftover bits from tooth development. They can be found in either the mandible or the maxilla.
And who usually gets them?
We see them in a pretty wide age range, but they're most common in people in their teens, 20s, and 30s. In the mandible, they tend to hang out in the back, the posterior body and ramus, which is the vertical part, and in the maxilla, they like the third molar area. Overall, they're about twice as common in the mandible.
Okay. And on an X-ray, what do they look like? You said they can resemble other cysts.
They often look multilocular on X-rays, like a bunch of little bubbles with well-defined borders and smooth margins. But here's the thing. A good chunk of them, maybe up to 40%, can also be unilocular, meaning just one compartment. And if it's just to an unerupted tooth, it can be really hard to tell it apart from a dentigerous cyst just from the X-ray. And another thing, they can cause the bone to expand outward. About 30% in the maxilla and 50% in the mandible will do that.
So they can cause some noticeable changes in the bone structure.
Right.
And you said their microscopic appearance is quite unique.
It is. The basal cell layer, that's the innermost layer of the lining, has this very distinctive palisaded pattern. The cells are all lined up nicely, like a row of soldiers. And the cells on the surface, the luminal cells, they're paracrinized and have a wavy surface. And what we used to call primordial cysts, those cysts that form instead of a tooth, we now classify those as OKCs because they have the same microscopic features.
So even though they can look different on X-rays, under the microscope, they have this consistent pattern.
Exactly. And another thing, the wall of an OKC is very thin and fragile. It's like trying to remove a delicate membrane. It's important to remove it completely, but even tiny pieces left behind can cause the cyst to grow back. That's why we tend to use more aggressive surgical techniques for OKCs, and we're very diligent about follow-up appointments.
Makes sense. So how do you treat them given their tendency to recur?
We go for surgical removal, but we usually combine that with other things to make sure we get all of it. We might do peripheral osseous curettage, where we scrape the bone around the cyst, or even an ostectomy, where we remove a thin layer of bone next to the cyst.
So you're basically trying to eliminate any trace of those cells.
Right. We're trying to get rid of any little satellite cysts or remnants of the lining that might be hiding in the surrounding bone. But even with all that, they can still come back, especially if the original cyst was large or in a tricky location. The recurrence rate is somewhere between 10 and 30%. And in very rare cases, an OKC can turn into an aloblastoma.
Okay, and you also mentioned that connection with nevoid basal cell carcinoma syndrome, right? Can you tell us a bit more about that?
Absolutely. It's really important to be aware of this. So this syndrome, also called Gorlin-Gold syndrome, is pretty rare. But one of its hallmark features is the development of multiple OKCs in the jaws. So if you see a patient with more than one OKC, or if they have other signs of this syndrome, you need to consider the possibility of Gorlin-Gold's.
What kind of signs are we talking about?
Well, they can have these basal cell carcinomas, which are a type of skin cancer, and they might get them at a young age and in multiple places. They can also have certain bone abnormalities, like bifid ribs, and they might have a broad nasal root, meaning the bridge of their nose is wide, and their eyes might be spaced further apart than usual. They can even have calcifications in their brain.
Wow, so this syndrome can have a pretty wide range of effects.
It does. So if you come across a patient with multiple OKCs, it's important to take a good medical history and maybe even refer them for genetic testing to rule out this syndrome.
That's a lot of information to digest. All right, let's move on to the calcifying odontogenic cyst, or COC, also sometimes called the calcifying cystic odontogenic tumor.
Right, the COC. As the name suggests, calcification is a key feature here.
Okay, calcification. And I see it can be a cyst or a tumor.
Yeah, it can be either. We consider them developmental odontogenic lesions. They can
Hmm.
recur occasionally. And there's this solid variant called the odontogenic ghost cell tumor, which some people think might be a little more aggressive. But the main thing is that they come from remnants of odontogenic epithelium, which can be found in the gums or the jawbones themselves.
And where does the calcification come in?
Well, COCs have this unique feature called ghost cell keratinization. These ghost cells are basically epithelial cells that have lost their nucleus but still have the outline of their cell membrane. So they look kind of pale and ghostly under the microscope. And these ghost cells can undergo calcification, which gives a cyst its name.
Ah, so that's where the calcifying comes from.
Exactly.
And who usually gets these COCs?
They can pop up at any age, but we see them most often in teenagers and young adults. Most people who are diagnosed with COCs are under 40, and for some reason, women seem to get them a bit more often than men, and over 70% of them are in the maxilla, the upper jaw.
Okay. So on an X-ray, would you always be able to see those calcifications?
It depends. They can look unilocular or multilocular on X-rays, and they usually have nice clear borders. Sometimes you'll see these scattered little white spots within the cyst, which represent the calcifications. They can give it a salt and pepper appearance, but not all COCs will have obvious calcifications on an X-ray.
Okay, so you can't always rely on the X-ray to tell you for sure. And how do you treat these cysts?
We remove them surgically, but because they can recur, we usually do a bit more than just a simple curettage, and we usually recommend follow-up visits to monitor the area.
All right, so that covers the main types of odontogenic cysts. Now let's switch gears and talk about non-odontogenic cysts, the ones that don't come from tooth-forming tissues. First up, we have the globule maxillary lesion. You mentioned it used to be considered a cyst. What's the deal with that?
Yeah, this is an interesting one. You see, back in the day, we thought globulomaxillary lesions were a type of fissural cyst. We thought they came from little bits of epithelium that got trapped during development when the globular and maxillary processes were fusing in the upper jaw. But now we know that those processes don't actually fuse in a way that would leave epithelial remnants behind.
So the whole idea of it being a fissural cyst was wrong.
Pretty much. So now, globulomaxillary is more of an anatomical term. It just refers to any lesion in the bone between the maxillary lateral incisor and canine teeth.
So if you see a radiolucency there on an X-ray, what could it actually be?
It could be a lot of different things. That's why you need to look at the clinical findings and examine the tissue under a microscope to make the diagnosis. And it's really important to test the pulp vitality of the nearby teeth. If a tooth is non-vital, then it's more likely to be a periapical cyst or granuloma. But the bottom line is that the histology, what you see under the microscope, can vary a lot. And that means the treatment and the prognosis will depend on what that specific diagnosis is.
So it's not a cut and dried situation.
No, not at all.
All right. And then we have the median mandibular lesion, which also used to be called a cyst. Same kind of situation there.
Pretty much. We thought it was a fissural cyst, too, forming from trapped epithelium, where the two halves of the mandible were thought to fuse. But newer research has shown that the mandible develops differently. There's no epithelial fusion there. So, just like with the globulomaxillary lesion, median mandibular is more of a location than a specific diagnosis.
So if you see a radiolucency in the middle of the lower jaw, what do?
You do vitality testing on the nearby teeth, and you look at the histology of the lesion. The treatment will depend on what the microscope tells you. Sometimes it might even look like a calcifying odontogenic cyst under the microscope.
Okay, so a biopsy is usually needed to figure out what's really going on. Now let's talk about the nasopalatine duct cyst, also called the incisive canal cyst or the cyst of the palatine papilla.
Okay, so this is an interesting one. This is actually the most common non-odontogenic cyst.
The most common. Wow. All right, tell us more.
So it comes from remnants of these little ducts, the nasopalatine ducts, that run through the bone in the front part of the maxilla, right behind the front teeth. If the cyst is inside the bone, in the incisive canal, then it's called a nasopalatine duct cyst or an incisive canal cyst. But if it's in the soft tissue of the palate, near the opening of that canal, then it's called a cyst of the palatine papilla.
Okay, so same origin, different location, different name.
Exactly. And then there's the median palatine cyst, which is further back on the roof of the mouth. We used to think it was a separate entity, but now we consider it to be a more posterior form of the nasopalatine duct cyst.
So what causes these nasopalatine duct cysts?
Well, they come from the epithelial remnants of those nasopalatine ducts that are left over from when the palate was developing.
And who's most likely to get them?
We see them most often in middle-aged adults, people between 40 and 60. And for some reason, men get them way more often than women.
Really? Why do you think that is?
Honestly, we don't know for sure. It's one of those mysteries of the human body.
Okay, fair enough. So would someone know if they had one of these cysts?
Not always. A lot of times, they're asymptomatic, meaning they don't cause any symptoms. People often find out they have one when they get dental x-rays. But sometimes there might be some swelling in the front of the palate, or they might have a salty taste in their mouth, or even some drainage.
And what about on those x-rays? Is there a typical appearance?
Yeah, they usually have a pretty classic look. They show up as this well-defined, dark area, or radiolucency, right in the middle of the front part of the maxilla. And they often have a heart shape or an inverted pear shape. Sometimes they can push the roots of the central incisors apart a little bit, and in rarer cases, they might even cause some resorption of those roots. But importantly, the teeth involved are almost always vital.
Okay, so vital teeth are a key feature here. What about under the microscope?
The lining of these cysts can look a little different depending on where they are. It can be stratified squamous epithelium, which is the normal lining in the mouth, or it can be pseudostratified columnar epithelium, especially if the cyst is closer to the nasal cavity. You might also see some mucus glands or nerve bundles in the cyst wall.
Okay, so a variety of appearances under the microscope, and how do you treat them?
The usual treatment is surgical enucleation. That means removing the whole cyst and its lining. If it's a really big cyst, the surgeon might do a marsupialization first to make it smaller before removing it completely.
Marsupialization, that sounds familiar.
Yeah, we talked about that with dentigerous cysts too. It's basically creating a window into the cyst to let it shrink. Anyway, the good news is that these nasopalatine duct cysts have a low recurrence rate once they're completely removed.
That's good to hear. Okay, let's move on to the pseudocysts now. These are the ones that look like cysts on x-rays but don't have that epithelial lining. First up, we have the aneurysmal bone cyst, or ABC.
Ah, yes, the ABC. This one's a bit of a mystery, even for us experts.
A mystery. How so?
Well, we know they show up as these cyst-like things on x-rays, but when you look at them under a microscope, there's no epithelial lining, so that's why we call them pseudocysts. But we're not entirely sure how they develop. There are some theories, of course.
Like what?
Some people think they're caused by trauma, like a blow to the jaw. Others think it's more of a vascular thing, a problem with the blood vessels in the bone. And some even think they might be a type of tumor.
So lots of possibilities, but no definitive answer.
Right. It's an area of ongoing research, actually. There are researchers who are looking into genetic mutations and changes in signaling pathways within cells that might be involved in their formation.
So who usually gets these ABCs, and where in the jaw are they found?
We tend to see them more in younger people, under 30, and slightly more often in women. They usually hang out in the back of the jaws, both the mandible and the maxilla, especially around the molars.
Okay. And how do they look on an x-ray?
On x-rays, they often look like this rapidly growing destructive area with irregular borders. Sometimes they have that multilocular look, like soap bubbles, and they can push the teeth around and even cause some resorption of the roots.
So they can be pretty aggressive.
Yeah, they can.
And if you look at an ABC under the microscope, what would you see that confirms it's not a true cyst?
What you'd see is this fibrous connective tissue with lots of blood-filled spaces and some multinucleated giant cells. But the key is that there's no continuous epithelial lining surrounding those spaces. That's the hallmark of a pseudocyst.
Okay, so no epithelial lining means pseudocyst. Got it. And how do you treat these given that they can be aggressive?
Simple curettage, just scraping it out, doesn't usually work that well. They tend to.